welcome Patrick to Grand Rounds. He has, as you know, been very helpful with our medical oncology issues. His research is even more important as we begin to look at glioma and the genomic alterations. And his title is perfect because we're finding out that it is the genes which are determining outcome and efficacy of treatment. And this is the brave new world we enter of personalized medicine. So, Ian, would you go ahead and introduce Patrick a bit?
Sure. As strange as it may seem, Patrick's career in neuro-oncology really started in high school. At that time, he worked in one of the premier neuro-oncology laboratories of Dr. Jan Sikaria at the Mayo Clinic. And then he continued to work there into college. And then later in college, he worked in a brain tumor immunology lab of Dr. John Olasfest. And this was at the University of Minnesota. He then pursued a PhD in neuro-oncology and completed that at the University of Michigan. He went to medical school at the University of Kansas and graduated with distinction. And then we lured Patrick here as a UW Impact clinician researcher candidate. And so he did his internal medicine residency here at the UW. He then has continued on as an oncology fellow, doing both clinical and laboratory research in neuro-oncology. He just obtained a very distinguished award, the American Society for Clinical Oncology Young Investigator Award. He's published over 30 manuscripts. He is the only oncology fellow to serve as a standing member of our Chemotherapy Council, as well as the UW Precision Medicine Molecular Tumor Board. His comments during our tumor boards have really been very insightful. So we're really fortunate today to have Patrick speak to us about the potential and application of precision medicine and some of the really exciting research he's doing now in the laboratory.
Thanks, Ian. Really appreciate that. Dr. Dempsey as well. Thank you guys both for the kind introduction. And good morning to everybody else. As mentioned, I've been asked for the next 40 to 45 minutes to talk about this really interesting and in many ways revolutionary topic of precision medicine in glioma. And we could probably have about 5 or 6 of these on that topic alone. Obviously, we don't have time for that. And so I'm going to really try to hit the highlights of where we've been, where we are, and in many ways where we're going in this particular field. I think my slides are trying to advance, but we will give it a moment here. There we go. So I have no disclosures, no conflicts of interest. Of note, I do work in the laboratory of Dr. Dusty Deming, and I am a clinical and research fellow of Dr. Robbins. As I mentioned, there's a lot to cover when it comes to precision medicine in glioma. And I think it's really important, first and foremost, to define what precision medicine is in the realm of oncology and other diseases for that matter. We'll go on to talk about a little bit about standard of care testing that we do already and how that's been impactful in the management of our adult gliomas. I'll specifically talk about adults today because the pediatric disease is certainly a bit of a different one. How we have been incorporating widespread molecular sequencing or genomic sequencing into our patients, both as a field and certainly in our own institution. How we've utilized those findings for precision-based therapeutic trial strategies. And then last but not least, I'll go into a little bit of detail about what we've been doing in the laboratory to try to evolve upon what the field has been doing thus far. Now, precision medicine, very interestingly, was actually originally coined as personalized medicine in popular media. It wasn't something developed by, at least a term developed by the scientific community. It actually came out in the late 90s as in the Wall Street Journal. And really, this term has evolved into precision medicine. But the idea is fairly similar, that ultimately we are looking at a patient's disease or their situation, trying to identify unique features to that, and then tailoring management decisions to a subgroup of patients rather than this blanket one-size-fits-all approach. So we're not just throwing chemotherapy at everybody, we're really trying to make smart decisions that impact folks in a better way. And I think while most folks think of precision medicine as utilizing targeted therapy, and frankly, I do a lot of times as well, because this is probably one of the most common uses of the term, and how we utilize this and integrate it into patients with specific mutations. Ultimately, there are a number of other components to precision medicine as well. Germline testing, so did you inherit something from your mom or your dad that we can look at? Protein levels, completely independent of whether those proteins are mutated or not, whether patients have unique imaging characteristics that we can exploit, and certainly last but not least, components of the patient themselves. Are they a fast metabolizer of a drug or a slow metabolizer of a drug? What's their volume of distribution, et cetera? All things that ultimately impact the way that we can hopefully more effectively provide management for patients, but also do so in a safer, more strategic way. I think we're all familiar with this gentleman here. Interestingly, in the 2015 State of the Union address, he actually allocated several $100 million for something known as the Precision Medicine Initiative. And as a result of that, NIH, over the last 5 or 6 years, has allocated a great deal of additional money for the study of precision-based strategies, whether we're talking about cancer or whether we're talking about other diseases, although most of this money went towards cancer. And that, of course, begs the question, with the precision medicine boom and the interest that precision medicine has taken in the realm of many diseases, and certainly cancer as a whole being one of them, is there a way that we can exploit that in brain tumors, and for the purposes of this talk, glioma, and how do we do so? And I would argue that, number one, this is something that has been ongoing already for some period of time. And number two, we're really in an exciting boom of this, where that role is evolving, and as Dr. Dempsey mentioned earlier, will continue to do so in the immediate future. Really fascinatingly, neuro-oncology was actually one of the earlier adopters of molecular testing in precision management-based strategies of our patients. And a great example of this is with glioblastoma. Now, you're an audience where I don't really need to go into the background of glioblastoma. I think we're all aware that this is certainly a devastating tumor. It's the most common and certainly the most aggressive primary malignant brain tumor that exists. There was a gentleman named Roger Stoop, still is a gentleman named Roger Stoop, who was actually did his medical oncology fellowship just south of here at the University of Chicago. He then went back to his home country of Switzerland, where he joined a relatively small hospital, but interestingly became the head of a really pinnacle trial for glioblastoma. There was a drug that we've all talked about named Temozolomide that was studied in the late 90s and the early 2000s in the lab and in some early preclinical work. And ultimately, this chemotherapeutic came to light when it was combined by Dr. Stoop and colleagues with radiation therapy and then after radiation therapy in the management of gliomas, and specifically glioblastoma. And what was seen was actually really fascinating. For the first time in quite some time, actually ever, temozolomide demonstrated a survival benefit in patients with glioblastoma, albeit only about 2.5 months, but this was something that was fascinating for folks. We know that temozolomide is an oral alkylating chemotherapeutic agent. As a result of that data that I just presented, it was approved by the FDA fully in 2005. It does cross the blood-brain barrier, albeit to a somewhat limited extent. Only about 8% of it gets in. Now, what temozolomide does is it functions to methylate guanine, predominantly at the O6 position in terms of functional relevance, though other sites as well. And what happens when guanine is methylated is that it mispairs. The DNA gets kind of screwed up, and ultimately the glioblastoma attempts to repair itself through a repair cycle known as mismatch repair. But it essentially burns itself out, and the cell, in many cases, ends up dying if this damage isn't able to be repaired. Now, a fraction of glioblastoma patients express a protein known as methylguanine O6 methyltransferase. It does what its name says. It comes in here, it cleaves off this insult that the temozolomide introduces, and ultimately the DNA goes back to normal, and the cell survives, and it does what it was doing before. It grows and divides and does the things that we don't want it to do. So effectively, MGMT is a resistance mechanism. So when the authors of the SHOOT trial went back and looked at the MGMT status of patients in that original trial, they saw something really fascinating. And so we consider, and this is a term that we use oftentimes in the tumor board, we talk about tumors as being MGMT methylated. It means their promoter site is methylated, the gene is turned off, and thus they lack MGMT. They lack that resistance mechanism. In contrast, those folks that are unmethylated, that gene is turned on, and they express MGMT. So that's about a 4 to 6 distribution. So less folks have the lack of resistance mechanism. And when we look at those folks that lack the resistance mechanism, perhaps not surprisingly, these are the folks that really get the bang for their buck on the temozolomide. They get about 8 months out of temozolomide compared to radiation therapy alone. And in contrast, those folks who have unmethylated disease really don't get a whole lot out of this. These are folks who don't have a statistically significant benefit from temozolomide, albeit there is this tail that would otherwise suggest that some patients benefit. And we now know that this likely represents a large number of patients who were false negative tests, who actually should be classified up here, or otherwise have other alterations or a different disease type that make them sensitive to temozolomide. So this is probably a false tail, but it's a way that in many ways the field still justifies giving temozolomide to unmethylated patients in certain cases. The other thing, in addition to predicting response to temozolomide that we've seen, is that those patients who lack the resistance mechanism, who are MGMT methylated, do a lot better than those folks who are unmethylated, regardless of whether they get chemotherapy or not. And so what this showed was that the MGMT methylation status not only was predictive for response to how patients were going to do with temozolomide, but it was also prognostic with regard to, in general, regardless of chemotherapy, the outcomes of patients. And so really, MGMT has been one of our first precision-based strategies in glioblastoma, and thus neuro-oncology has been a pretty early adopter of this. In 2016, the World Health Organization revised its 4th edition of classifications for CNS tumors, and glioma was included in that. And this is a bit of a busy slide, so I want to draw your attention to 2 really important things that we'll talk more about. One, and both are introduction of molecular features. So one of those was the addition of the 1p19q co-deletion. What does this mean? This means that the short arm of chromosome 1 and the long arm of chromosome 19 are deleted. And if you see that, ultimately this has been termed a disease-defining molecular alteration for an oligodendroglioma. Also, what was broken out in this particular update is whether a patient was IDH, isocitrate dehydrogenase, a term that we also talk about in the tumor board a lot, whether they were mutant or whether they were wild type, meaning they lacked the mutation. And I'll show you momentarily why that was important. First and foremost, the 1p19q co-deletion. So this is probably best demonstrated in the RTOG 9402 trial. It does not matter at all for the most part what this trial was, but I think it's important to emphasize that this was a trial where the investigators thought that they were looking at anaplastic or grade 3 oligodendrogliomas. And ultimately, what they found was fascinating. When they retrospectively went and looked at the patients that they included in this trial, who they thought were oligodendrogliomas, they actually found that less than 50% of them had this 1p19q co-deletion, meaning that only a subfraction of them were truly oligodendrogliomas. And regardless of whether patients got radiation or radiation with chemotherapy or radiation alone in this trial, patients who had this 1p19q co-deletion and were considered oligodendrogliomas did a heck of a lot better than those folks who lacked that alteration. So essentially, it was a delineation between oligodendrogliomas and astrocytomas. Additionally, in this trial, when they looked at those folks who had the co-deletion, those who were oligodendrogliomas, they saw that these folks were the ones that really got benefit from adding chemotherapy to radiation and did much better than radiation alone. And this was statistically significant. Whereas those folks who lacked the alteration, those who were astrocytomas, really didn't get any statistically significant benefit out of adding chemotherapy. So not only is the 1p19q that we talk about a predictive marker of how folks are going to do, it's a prognostic marker of how folks are going to do, it's also predictive of how they respond to chemotherapy. And the takeaway from this is that these folks all, when they entered the trial, looked like oligodendrogliomas under the microscope. But in reality, we now know that these molecular findings are critical. You can look like an oligodendroglioma, but if you lack the 1p19q co-deletion, you're not an oligodendroglioma, you're an astrocytoma, meaning the molecular features are even more important than what our eyes are seeing. The other important component to this is the IDH, or the isocitrate dehydrogenase mutation. And there have been a number of pieces of literature that have evaluated this. Probably the best one and the most up-to-date one is with the CATNON trial, which is an ongoing phase 3 trial looking at grade 3 or anaplastic astrocytomas. And the goal of this trial has been to figure out what's the best way to treat our anaplastic patients, our anaplastic astrocytoma patients. So they were randomized to one of 4 arms. Either they got radiation, They got radiation with temozolomide, which is concurrent temozolomide. They got radiation followed by temozolomide, which is adjuvant temozolomide, or they got radiation with both sets of temozolomide. And this is an ongoing trial, and so data is constantly being released. We still do not have the MGMT methylation data breakdown, but earlier this year they did release the IDH status breakdown in terms of how folks do. And what we found was actually really interesting. Those folks who are IDH wild type, meaning they don't have the mutation, whether you give chemotherapy with or after radiation, they get no benefit at all out of temozolomide, adding that temozolomide in. In contrast, the IDH mutant patients who get temozolomide during radiation may get a little bit of benefit from it. It isn't statistically significant, and we're hopeful that when the MGMT data breaks out, we'll have a better understanding of what patients may truly benefit to temozolomide with radiation. But the real key that was seen is that adjuvant temozolomide given after radiation, was critical to the improved survival of patients with IDH mutations, suggesting this is really a predictive marker of response. And on top of that, much like what we saw for MGMT and the 1p19q, we saw that IDH wild type patients did really poorly overall. So their median prognosis, their median survival was less than 2 years on the whole, again, regardless of chemotherapy. But in contrast, even regardless of chemotherapy, those who had this mutation did very well. They were going out 7, 8, 9 years. And as you can see, there's a plateau on these survival curves, suggesting that many of these patients in the right situation are actually getting cured. So it really is a prognostic marker too. And thus, we know that this MGMT, IDH, and 1p19q have been critically important as really truly precision-based strategies already in understanding patient glioma, as well as understanding the response to chemotherapy. But with all of this having evolved over the last handful of years, I think it really begs the question, is there more that we need to do? Is there more that we need to learn? Is there more that we need to know? And with that being said, this talk would end here if the answer to that was no. The answer is clearly that we're still in an evolutionary field of precision-based strategies for neuro-oncology, and that there are other things that we need to be concerned about. There's a group known as the Consortium to Inform Molecular and Practical Approaches to CNS Tumor Taxonomy. That's a mouthful. We refer to this group as the C-Impact Now group, who basically are a group of pathologists and other providers who have been providing updates, specifically molecular updates, since those WHO guidelines were updated in 2016. And they've done it for all CNS tumors, but glioma have been included in that. And it's really critical to identify or to outline that there have been 7 updates over the last 5 or 6 years because of the boom of molecular understanding that we've had in neuro-oncology as a whole. And obviously that will continue as time goes along, but I'd like to highlight 2 of those updates for our glioma patients. The third update that they issued was in IDH wild type patients, so those who are expected to do particularly poorly with grade 2 and grade 3 astrocytomas. And what they said was that if these patients had molecular features that were of particular concern, that even though they look like grade 2s and grade 3s under the microscope, the reality is that they could be termed or would be considered a grade 4 or truly a glioblastoma. Again, what's more important is the molecular feature than truly what we're seeing under the microscope. And what are those molecular characteristics? Well, they could either gain chromosome 7 and lose chromosome 10. They could have a mutation in the promoter site of the telomerase reverse transcriptase, or TERT, which increases production of telomerase. And with telomerase, as we know, it maintains genomic integrity, which is not what we want in glioblastoma or glioma in general. And epidermal growth factor receptor amplification, EGFR amplification. This is a tyrosine kinase receptor, which enacts proliferative signaling. So again, a bad thing in cancer. And what these folks have proposed is that if these tumors, these grade 2s and grade 3s under the microscope, had these molecular alterations, that they would behave a lot worse than what their histology would suggest. And indeed, this was confirmed with retrospective multicenter data. When those folks with, so as an example, the green line here are folks with histologic grade 2s and grade 3s, but also have those non-concerning molecular features. And they do kind of like what we'd expect for a grade 2 or a grade 3. The purple line here are those folks that we traditionally know as glioblastomas. They do particularly poorly, again, as we kind of expect. But the orange line here are those that look like grade 2s and grade 3s under the microscope, but they harbor one of those molecular alterations that we talked about. And these folks, again, regardless, I can't emphasize this enough, regardless of what they look like under the microscope, they behaved almost identically to glioblastomas, and thus the molecular findings are critically important to these folks. The other thing that that the See Impact Now group did in their fifth update was provide an update for the IDH mutant, those folks who are predicted to do much better, grade 2 and grade 3 astrocytomas. And so similarly, what was proposed was that if a different alteration, a loss of the gene known as CDKN2A or CDKN2B, this codes for suppressors of progression of the cell cycle, so again, a bad thing, so you're losing a tumor suppressor, these being P14, P15, and P16 for reference, that if you lost that these grade 2s and these grade 3s would no longer be considered that, but rather a grade 4. In this particular case, not truly a glioblastoma because the IDH mutant, but a grade 4. And again, the proposition is that the tumor behaves worse on the basis of its molecular findings rather than its histology. This is a bit of a busy slide, but I think it highlights that point very well and was what was used in part to justify this. This was retrospective multicenter data. I'll draw your attention to the blue lines here. The solid blue line are grade 3s, anaplastic astrocytomas, who lack that CDKN2A deletion. But the dotted blue line are those folks who are grade 3s who have that alteration. And again, these folks on the survival curve do a lot worse than those who lack that alteration. In fact, they do essentially as poorly as glioblastoma. And so what this shows us is that molecular genomics are critically important in how we even think about glioma these days. So putting this all together, I think it's really important to recognize that within the upcoming, probably within the next year or two, when the World Health Organization puts out its 5th edition of classifications, these findings are almost assuredly going to be incorporated into that. And obviously, with the plethora of molecular changes that we've seen, there will be more to come. And it also represents a really interesting thing for neuro-oncology. Oftentimes, we'll send off widespread mutational sequencing to try to identify a treatment for a patient with a cancer. And this is for oncology as a whole. But this really identifies to us that neuro-oncology, short of some hematologic cancers, neuro-oncology will actually be one of the first fields that requires extensive molecular sequencing, not only to try to identify therapeutic options, but simply even to understand the diagnosis and to truly make that diagnosis. So to put that a little bit differently, if you do a surgery on a patient and their pathology comes back as a low-grade glioma, I think it's important to recognize that we will, number one, need to get molecular testing on these patients. We do that standard for all of the patients that we have that come to our clinic, but that it's important to wait to really truly have that discussion about what their disease is and what their prognosis is until this full testing returns. And it also, from a neurosurgical standpoint, continues to emphasize the importance of what you already know, that tissue is critically important. And so necrotic tissue that can't be well sequenced is a problem. And so for those folks who end up, for example, undergoing a biopsy only, trying to optimize the amount of tissue and the amount of good quality tissue that you can get is certainly going to be of utmost importance. With that being said, obviously, we've had a lot of molecular components that we now use as standard of care and some that are evolving into standard of care that help us understand these patients a lot better. But the reality is that over the last 15 or 16 years, since temozolomide was introduced for glioblastoma, we really haven't had any meaningful advancements in systemic therapy. And obviously for those patients who are MGMT unmethylated, those not predicted to respond to temozolomide, they've gone decades without meaningful advancement in therapy. And so what that really begs is a need for alternative approaches, as we all know, for glioblastoma management. Obviously, surgical management is critically important. We know that the extent of resection is really well associated with how patients do, and we have radiation. But that being said, we're in a tough spot with systemic therapy. When we here at our institution, this is our data, sequence a number of glioblastoma patient tumors, each patient is individually represented horizontally. What we essentially see is a really heterogeneous disease. We see a wide array of various mutations, deletions, amplifications, and these are just some of the more common ones that we see. And this is true whether they're MGMT methylated or MGMT unmethylated. Every once in a while, we get lucky when we're working with a patient and sequencing their tumor. This is a gentleman who was diagnosed with an MGMT unmethylated glioblastoma, and here's his initial imaging. He underwent what effectively was a gross total resection, and this was his MRI prior to radiation therapy. with questionable regrowth versus what at the time was called post-treatment, post-surgical changes. And so this patient went on to receive radiation, and on his first MRI after receiving radiation, he had substantial regrowth of disease, which correlated with perfusion here. So it was true regrowth, suggesting that he was essentially radiation refractory. And he was in a really particularly tough spot. He's MGMT unmethylated, so there's really no benefit to chemotherapy in his case. He obviously just received radiation, so he's too early for retreatment radiation. And on top of that, he obviously just had no benefit from radiation, or very little benefit from radiation. This is a patient who had very little edema as well, so Avastin wasn't an option. So short of doing a surgery for which we had nothing to follow it up with, this is a patient who unfortunately would have been close to eligible for hospice. And what we found, interestingly, when we sequenced his tumor was a really unique mutation known as an NTRK2 fusion, or an NTRK fusion. And what happens in this particular case is a gene, two genes get slammed together, one of them being NTRK being a tyrosine kinase receptor, which because of this fusion, the product is constantly turned on, and it's constantly telling the cell to grow and divide. And this is something that we actually have a drug for in the realm of other cancers. And so after his insurance originally disapproved one of the drugs, we were able to get another drug known as entrectinib on compassionate care use through the company Genentech. And he actually had a really incredible response to this, given his situation. After about 8 months, he achieved the maximum response that we had seen, about a 2/3 reduction in enhancing tissue. And the patient still remains on this drug after a total of 14 months with stable disease and excellent quality of life. And so this really emphasizes that precision-based strategies, as we continue to learn from them more, are really important in helping patients out, buying them time, and certainly buying them good quality of time. And this is just one introduction to what we're hopeful for the future. Of note, the entrectinib has never actually been used in an adult glioblastoma patient before, and this is the first successful or unsuccessful, in this particular case successful report of that, and so we're actively writing this up. Now, genomic alterations in glioblastoma have been studied for some time. Glioblastoma, interestingly, was one of the first cancers to be profiled as part of the Cancer Genome Atlas project about 2 decades ago. And without going through all of the details, what we saw were a wide array of amplifications, deletions, mutations, fusions, et cetera, all things that we saw with our data. But ultimately, what these things do is they cause dysregulation within the cell, they activate proliferation and survival pathways, and ultimately, they explain in part why glioblastoma is one of the fastest growing glioma tumors, one of the fastest growing tumors based on doubling time that's out there. Whether we're talking about lung cancer or breast cancer or glioma, this is unfortunately it. Because of these findings, there have been a number of attempts from a precision oncology standpoint to conduct clinical trials that target various things that we see altered in these patients. EGFR has been one of those, various approaches to target this. This is a tyrosine kinase receptor, as I mentioned earlier. This is frequently amplified or otherwise turned on in glioblastoma, about 50% of patients. And despite attempting to use antibodies conjugated to chemotherapy, small molecule inhibitors, and various immunotherapeutic agents, all of our trials to date have thus far been negative in that realm, unfortunately. This has probably been the most heavily studied target in glioblastoma. Other things that have been attempted to date are PI3 kinase inhibitors. PI3 kinase is frequently activated, or we've lost PTEN, which is a suppressor of this pathway, leading to activation of the PI3 kinase AKT-mTOR pathway. Buparlisib, despite reaching the tumor, showed a 0% response rate in GBM. Paxilosib is currently being studied. It's only been released last year as a press release. And what was suggested was a 3.2-month progression-free survival benefit compared to historical controls, although we all know that comparing things to historical controls rather than a true control within the study is quite limited, but there yields some promise there, and that trial is ongoing. CDK4 and 6 inhibitors have also been used. As mentioned before, not uncommonly, CDKN2A/B or A or B loss is frequently seen, and ultimately this takes off the suppressive pressure of cell cycle progression. It leads to activation of CDK4 and 6, and we have inhibitors for this. And these are frequently used in the breast cancer realm. Abemaciclib, based on preclinical data and breast data, is well known to cross the blood-brain barrier. But despite this, as a monotherapy against glioblastoma, there's been no survival benefit, whether we use this recurrently or in the upfront setting for these patients. Perhaps a little bit more promisingly, BRAF, a protein within the MAP kinase pathway, frequently has an alteration known as V600E. This is something we see in melanoma pretty commonly, and it leads to activation of the MAP kinase pathway. Vemurafenib is a small molecule inhibitor against BRAF, and in a fairly limited trial of glioblastoma, there were some stable diseases that were achieved, but ultimately a 0% response rate. None of the tumors shrunk. In contrast, maybe a little bit more promisingly, dabrafenib, again, an agent that targets BRAF combined with a downstream inhibitor called trametinib in a phase 2 study, actually showed about a 50% response rate in patients under the age of 40 with buying about a year and a half of progression-free survival time. Now, this was in high-grade gliomas, and the younger cohort is certainly clouded by the fact that some of these are probably grade 3s rather than glioblastomas, but it suggests some promise. In contrast, though, those patients who are over the age of 40 really don't get any benefit from this. Their progression-free survival was about 2 months, meaning until the next MRI, and effectively that means there was zero benefit. The other thing that we talked about previously as well are these NTRK fusions based on our own patient. Larotrectinib was the agent that was denied for our patient, and in a cohort of gliomas, about 5 of which were glioblastomas, there was a 100% disease control rate, meaning keeping it from growing, and about a third of patients actually had a shrunken size of the tumor and a 50% response rate in glioblastoma. So this is probably a lot more promising. The challenge, of course, is that this is a lot more common in pediatric gliomas, which behave differently, and only 4 of the 14 patients seen here were even adults. So with that being said, obviously what I'm presenting gives you a bit of an idea that there's both promise and some skepticism within the idea of precision medicine for glioblastoma and other gliomas. But it's important to recognize that many of these prior trials, especially some of the unsuccessful ones, were enacted in an era where sequencing was not routinely done on patients like we routinely do now. They understood that a certain number of patients had alterations like an EGFR amplification, and investigators would take an EGFR inhibitor, pull it off the shelf, and try to give it to patients in trials. And we now have a much better way of identifying which patients may actually respond to these therapies and who we should forget about in terms of targeting, because it's just not going to benefit. And so we have a lot of excitement about that, as well as a lot of the data that's coming forth in current days about how precision-based strategies can more effectively manage glioma patients. And we've got a number of projects ongoing in the laboratory for this. I'll highlight several of them today for the purposes of the time that we have. First and foremost, as Ian had mentioned, we did get some funding. I got some funding to study a phenomenon known as post-surgical regrowth in glioblastoma and how that correlates to molecular findings. When we look at, these are 2 examples of patients. When we look at 2 patients, A and B here, both of whom were diagnosed with glioblastomas, both underwent very nice resections. But by the time they made their way to our clinic and the radiation oncology clinic, they had a restaging MRI, and what was seen was massive regrowth of these tumors. And obviously this begs the question, 2 questions. Number one, what good did we do for them if we did a craniotomy and couldn't treat them earlier and ultimately were in a worse position than we started? And the other question, of course, is there a way that we can potentially optimize therapy earlier for patients who have this phenomenon? And so the work that we're doing actively is looking at molecular correlates, so sequencing, mutational analysis, as well as various findings within the tumor microenvironment to better understand this. As some very preliminary data, what's really intriguing to us is that when patients have lost this CDK2A gene that we talked about, or have amplification of CDK4 and 6, which is related to this, the vast majority of the time, these patients either have clear evidence of substantial regrowth prior to receiving radiation, or at least radiographic concern per our neuroradiologist. But when neither of those are present, patients are very unlikely to have regrowth. And thus it suggests a phenotype that we need to be concerned about in these patients. And it really clearly helps to define, in many ways, the biology of the tumor and potentially identifies things that are important to target despite some of the monotherapy struggles from previously. When we go back and look at our data for sequencing patients, again, we see that there's quite a bit of heterogeneity. But when we look within this heterogeneity, we see some common themes. And those common themes include alterations in similar pathways. So the gold that's highlighted here are alterations within our CDK retinoblastoma pathway for cell cycle regulation, which is screwed up in this regard. And the blue highlights alterations that activate the PI3 kinase AKT mTOR pathway. And not only are these occurring within a variety of tumors, but we're also seeing that they're occurring within the same individual's tumor. And what that suggests is that there's not a clear driver alteration in many cases. If you target one pathway, ultimately the other pathway is still active and signaling and doing the things that we don't want it to do. And what it does is beg the question, are there targeted therapies that we can combine to ultimately increase our anti-cancer efficacy in this regard and potentially limit the escape pathways of simultaneously activated pathways and proteins? And I've proposed doing this in part by combining a PI3 kinase mTOR inhibitor known as copanlisib and the CDK4/6 inhibitor abemaciclib in a rational way with two drugs that in theory have side effect profiles that probably can be safely combined in patients. Briefly, copanlisib is a pan-PI3 kinase inhibitor. It does have some anti-mTOR activity as well. It's approved in follicular lymphoma by the FDA, but there are innumerable trials ongoing in the solid and hematologic realm to see where we can best employ this drug. And it does have some phase 1 data to suggest that it crosses the blood-brain barrier. Abemaciclib, as we talked about previously, is a CDK4/6 inhibitor, certainly well studied in breast cancer and certainly well known to cross the blood-brain barrier. And when we look at these drugs as monotherapies in glioblastoma cell lines that harbor alterations in both of those pathways, we see modest activity of the drugs with some variability amongst the lines, but some modest activity as monotherapies. When we look at a vast array of over 20 primary glioma stem cell lines, so primary lines that we've taken directly from patients with your help, these are patients some of whom we're actively still treating. What we see are some interesting findings. Copanlisib on the top, abemaciclib on the bottom. The yellow boxes represent concentrations of drug where over a 5-day period we either completely suppress the growth of these cells or otherwise regress the number of cells that exist. And so that's an important qualifier. Even if it slows the growth, if these tumors are still growing, it's kind of a meaningless endpoint. And so what we see is a great degree of heterogeneity amongst the copanlisib treatment, albeit most of the tumors responding to therapy at doses that we can actively achieve, which is above the red bar. In contrast, for abemaciclib, as a monotherapy, many of these patients do not, in fact, most of them, these patient lines, they don't achieve a meaningful response to monotherapy at the concentrations that we can achieve. And what's somewhat unfortunate about this is that simple preclinical data like this could have avoided those negative trials in abemaciclib that we talked about previously. This really is an easy predictor that patients are going to fail with that therapy. When we look at these drugs as monotherapies, they do what we expect molecularly. Copanlisib suppresses phosphorylation and thus activation of the PI3 kinase AKT-mTOR pathway, and abemaciclib reduces phosphorylation of retinoblastoma protein, keeping it in its active state and thus suppressing cell cycle progression. But importantly, when we combine these drugs in highly replicative cells, we see that combination therapy, as indicated here, for example, has significantly greater benefit and actually regresses cell numbers over a 6-day period compared to monotherapy alone, when cells are otherwise 100-fold greater in number. And these are at concentrations that we can achieve. And when we look at these concentrations, we see that our combination indices are frequently below 1. And what that means is that we're seeing synergy. So in this particular case, adding these two drugs together, you're getting 1 + 1 not equaling 2, but equaling 3 or 4. You're getting a lot more bang for your buck with the combination. And this is also seen molecularly when we combine the drugs at very modest concentrations. We see a significant reduction with combination therapy in phosphorylation of RB protein and phosphorylation of AKT, among other things, suggesting that targeting these pathways not only have an effect on what were the co-activated pathways, but that there's crosstalk between the pathways, data I'm not going to present right now, but crosstalk between these pathways that ultimately allows for increased efficacy of combining the therapies. When we look to see what's actually happening, we see that patients, by flow cytometry, looking at markers of cell death like annexin 5 and propydium iodide staining, here through the yellow bar, suggests that combination therapy markedly increases cell death compared to monotherapy alone at higher concentrations. And when we use lower concentrations, when we look at combination therapy, we see an increase. Number one, we see a decrease in cell number, not unexpectedly, but we see an increase in the blue staining in these cells for something called beta-galactosidase. And beta-galactosidase is a surrogate marker for cellular senescence. And while we'd rather these cells simply die off and go away, these are very achievable concentrations, and throwing cells into a state of senescence, shutting them off semi-permanently or permanently, is an important endpoint because we know in some fraction of glioma patients who go back for a re-resection for concern of recurrence, who ultimately just end up having late radiation changes, that we still see glioma cells, atypical cells that exist within that necrotic tissue, but aren't mitotically active. They've probably been shut off by the radiation and thrown into senescence. And they're still sitting there months or years down the line. And so that's a meaningful outcome for our patients. We can also utilize a model of glioma stem cell neurospheres. So essentially this creates a pseudotumor in vitro. This is a cluster of primary cells that grow rapidly over a 6-day period and grow non-adherently. And we can see here that with our monotherapies of abemaciclib and capanoseb, we really don't get much of an effect, but just a modest effect. But when we combine the two drugs, we completely suppress cell growth compared to the monotherapy alone. And in some of the lines, we actually obliterate these neurospheres. So with that being said, we're actively working on this in animal models, and on the basis of this data and the availability of those drugs, we're hopeful within the next year or two to translate this into clinical trials, into a clinical trial. The other thing that I want to talk about very briefly today is a little bit of a different approach, where we take our understanding of the molecular genomics of glioblastoma and try to target it in a little bit of a broader manner with respect to kind of a precision-based strategy, as contradictory as that may seem. This is being done we're doing this by utilizing a heat shock protein 90 inhibitor, HSP90, in combination with a proteasome inhibitor. HSP90, as many of you may be aware, is a chaperone protein. It helps to maintain protein folding, stability, and in some cases degradation. And so when cells are under stress, which is oftentimes the case in cancer cells that have oncogenic signaling, reactive oxygen species, high turnover, et cetera, proteins are bound to misfold oftentimes. And many of the proteins that rely on HSP90 for their folding and function, many that we consider client proteins, are those proteins that we see within our genomic sequencing that are important in the realm of glioblastoma. And we know that HSP90 is overexpressed and activated within glioblastoma. And while monotherapy trials for HSP90 inhibitors have failed for any one of a number of reasons in a variety of cancer historically, we've wondered, is there a better way to potentially approach this? Because it seems so promising, in at least molecularly. When a protein misfolds, it really has one of two escape pathways. Either it refolds, which we can block by HSP90 inhibition, or it gets degraded by the proteasome. And we have inhibitors of the proteasome. And so the proposition is that if we can block both of these escape pathways through respective inhibitors, these proteins will then only become insoluble aggregates and something that are toxic to the cancer cells. We've proposed doing this by using a next generation HSP90 inhibitor, and this is something that crosses the blood-brain barrier and has better pharmacokinetics, in combination with marazimib, which is a next generation proteasome inhibitor, again with improved pharmacokinetics and pharmacodynamics, and also with preclinical evidence that it crosses the blood-brain barrier. And interestingly, when we combine these drugs, again, looking at cell growth over 6 days, not only are these cells with combination therapy no longer growing, we're getting a 90% or more reduction of the number of cells that exist, when otherwise without treatment, they're growing 100-fold. So very promising. And similarly, when we look at our neurosphere model, although our monotherapies may have some modest activity, they're still growing at very low concentrations. Notably, those concentrations of the onelespib that I was showing earlier are about 20 to 40-fold less than we can achieve in patients, this being about 20-fold less, so low concentration. But when we combine these drugs, we get complete suppression of growth, and in some particular cases, complete obliteration after 6 days of these neurospheres. Again, when we use flow cytometry, we see that combination therapy increases cell death, and that molecularly, we get increased cleavage of PARP and caspase-3, which molecularly represents apoptosis with the combination therapy. And importantly, the question is our mechanism at play, our hypothesis, really what we're seeing? And so when we stain for proteins that are ubiquitinated, those that are being targeted for the proteasome to be degraded, we see that with combination therapy, we get a huge amount of ubiquitinated proteins that are persisting, again, in the combination therapy group. And that not only are these ubiquitinated proteins not being degraded, they're also no longer present in the soluble fraction. They're in the insoluble fraction, and thus the toxic fraction, supporting our hypothesis. When we look at the specific proteins that make this up, as some examples, importantly, we see CDK4, CDK6, AKT, all sorts of important things that we know from our sequencing are very important in the management of glioma, sorry, in the proliferation of glioma. And thus, if we can shift these away from the active fraction and into the insoluble toxic fraction, it's kind of like a double whammy to the cell. So this is something that we're really excited about as well, that we're pushing forward and hope to at some point move into a clinical trial, an early phase clinical trial as well. But I know we're basically out of time at this point. And so I'd really like to just take one moment and emphasize to all of you that precision medicine is really the up and coming future, and in many ways the present in the management of gliomas and other things in neuro-oncology. This has been ongoing for a while with some of our standard of care, and hopefully I've relayed to you why the standard of care testing is so important and why we think about it. But integrating next generation sequencing will be really critical moving forward. We do it here, and we're certainly welcome to help you guys out if you have a patient who you think needs it. At present, it's a little bit complicated from insurance to get it done. So we're actively working on that, and I'm happy to help anybody out to standardize that. But again, glioblastoma, it's a very heterogeneous disease, and precision medicine approaches have been challenging. But we see a lot of promise, and I'm very hopeful that that what I've shown you from what we're doing in the lab amongst many projects also relays a great degree of potential future benefit. So with that, it obviously takes a village. I appreciate Dr. Deming letting me do his work in his GI oncology lab, and obviously Dr. Robbins for his immense support with this. And I don't know if we have time for questions, but I'm happy to take any. And otherwise, thank you very much for attending this morning.
Thank you, Patrick. As you say, a number of us have to run to our clinics and ORs, but this is outstanding. I can see that over the years I've been updating my glioblastoma tumor marker cheat sheet cards. They're going to have to be updated again, as you can tell. But the most important thing I'm learning is the collaborative nature of this sort of work. Surgeons, clinicians, oncologists from other areas, big data people. This is really important. And one of the reasons I'm pushing to get our markers done here in-house, so that we be the person that is really defining what markers are looked at rather than sending things out. Thank you very much.
Oh, thank you very much. Appreciated, everybody.
You bet. Thank you, Patrick.
Patrick, this is Benny Eskandar. This is outstanding, as everybody said. Question about your IDH data. We've always known that with grade 2 astrocytomas, they behave differently between adult and pediatrics. Are there molecular features that distinguish the two?
Yeah, that's a very interesting question. Are you talking about specifically between pediatrics and adults?
Yes.
Or between IDH mutant and...
No, between pediatric and adults. Because, you know, grade 2 in an adult is very different from grade 2 in a peds patient.
Yeah, it is. You know, it's interesting when we look, and I guess I've got a list of a lot of the alterations that we see in adult patients. But in the pediatric patients, in particular in some of the lower grades, oftentimes some of those alterations that I talked about, like NTRK fusions and other things that we oftentimes think about as being more targetable are very, I don't want to say they're prevalent to a great extent in pediatric patients, but certainly to a higher extent. When that C-Impact group has put out its updates, I want to say their fourth update actually put out an incredible array of subcategorizations for pediatric patients on the basis of these fusions and amplifications and things. And really, pediatrics in many ways is ahead of the adult realm in that, in part because these things are present to a higher extent in pediatric patients. But pediatric folks are now subcategorized much better than just simply IDH wild type or IDH mutant. You know, they have an NTRK fusion, they have a BRAF mutation, that type of thing. And so those things exist to a much greater extent in pediatric patients. You're absolutely correct.
Thank you.
I'll also just say, as a point of emphasis, molecular testing in pediatric patients for that diagnostic purpose, and because of the potential for targeted therapy in those folks, is probably in many ways, and I hate to say it because I both hate to say it and I love to say it, I think it's probably even more critical in pediatric patients these days than it even is for adult patients at the moment in terms of how we can utilize that data. Anybody else?
Sounds like we're done. Thank you very much, Patrick.
Thank you, guys.